Hello, everyone. Welcome to the Student Physical Therapist Insider Access page and video. In this video, we're going to talk about how pain is like an alarm system and a kind of a three-part analogy based on where your patients are in the continuum of their pain history to help them along the way. Now, the pain is like an alarm system analogy applies somewhat to acute pain, but really, as the explanation goes on, it is even better for those who have persistent or chronic pain. And this analogy was adapted from Adrian Lowe, and then we've kind of extrapolated on that. And then Jared Hall and I, in the book Making Sense of Pain, have taken it even a little bit further and kind of given you other scenarios to utilize with your patients. So what is pain? Lorimer Moseley says that pain is a multiple system output activated by the brain based on a perceived threat. There's a few key components here. It's a multiple system output, which we'll get into, and then also the perceived threat. So perceived automatically makes this a subjective experience, which you can understand why that quickly becomes more challenging to treat. Williams and Craig said that pain is a distressing experience associated with actual or potential tissue damage with a sensory, emotional, cognitive, and social component. So right there, we can see when we talk about a biopsychosocial aspect to treating pain, because it's a sensory experience and an emotional experience, and it involves the frontal lobe, and then also it involves the contextual factors of your life, such as your social interactions and your financial situation, it becomes very complex very quickly. Why is pain so challenging to manage? It's basically, it's so subjective that it's whatever the person says they're experiencing, they can be. And we can manifest pain just with our thoughts, and we can manifest pain with our mind through individuals who have phantom limb pain, where they have pain in a limb that's not even there anymore. So it's challenging to treat because of the true but subjective nature of pain. Current physiology of pain is a top-down approach. That means it happens here and then it goes down into the body. Before we talk about the current physiology, the old theory of pain, the gate control theory, was a bottom-up theory where the pain fibers were in the periphery, and then the pain fibers would let the mind know about the pain in the hand, for example, or the foot if you step on a nail. We now know that the gate control theory, or the old bottom-up theory, does not work and it's not accurate. So the more current pain physiology, and this is how pain actually operates, is that there's a stimulus from the environment, from the periphery. Let's say you step on a nail, and then nociceptors. It says pain receptor on there, but it really more is a sensory receptor. That activates. It goes through the peripheral nerve, and that's the afferent nerve fiber, through the dorsal root ganglion, and then it crosses over through the lateral spinothalamic tract, goes up into the brainstem, and then you can start seeing different areas that are activated in the brain, and that's the pain neuro-matrix. Once it gets to the top, then we decide if it's truly pain or if it's okay and we can continue on. The key word here is if deemed appropriate. So how do we decide whether or not that stimulus from the environment is going to be painful or not? Because if we all have the same pain tolerance, then this individual who's sitting on the edge of an iceberg here would be in massive amounts of pain, because there's this typically extreme cold environments can induce hypothermia, can induce pain, but clearly it doesn't in this situation. So if deemed appropriate is the key response, and that's why we can train pain, and we can train ourselves to become stronger and more resilient to different stimuli, and that's why one person is different than the other. Recent advances in our understanding of pain have disproven the belief of pain receptors, pain fibers, pain pathways, or an isolated pain center. We know it's much more complex, where there's a neuro-matrix in the pain of how we process pain. We know that we have millions of sensory receptors that are constantly surveying the area for activity, and then that's always relaying information back to the brain and central nervous system. So our modern pain science understanding is that pain is really more of our body's danger alarm system. And this system, it's not that we've just discovered this because it's new. It's been around, it's for thousands of years, and we've evolved just as we've evolved to our current society. So This is it's an evolutionarily primitive system. We know to pull away from a nail when we're about to when we step on it, because that is so well ingrained in our system. It's a basic physiological need, similar to food, hunger, thirst, safety, all of those things. So it's very primitive, and because of that, it's evolved over time to be very specialized at the same time. The primary purpose is to warn you about danger. Now, that warning is not always accurate. Sometimes, if you've had chronic or persistent pain, the alarm system goes off, but there's actually not any problem. And we're going to talk about that in a minute. I think it's important to know that there's almost always more than one cause to a disease, dysfunction, or a problem. So, if we're talking about neck pain, for example, yes, there's some biomechanical issues. There's likely some central nervous system changes that have occurred. There's some postural ergonomic things that you can work on. There's some muscle weakness. There's lots of different reasons that different issues can occur. So there's likely going to be multiple treatments. That's why some people will placebo effect and past experience do better with manual therapy. Other people will need more of an exercise approach. What the research says is that a multimodal approach to treating pain is the best. And that includes some manual therapy, a lot of patient belief and expectations included in that, and then also exercise. So we need a combined approach where the patient understands what's happening. So educating them on the problem, then using some manual therapy to change around that complex sensory experience, and then also exercising and getting their body more resilient at the end. So persistent pain in the sensitive nervous system. This question actually came from Adrian Lowe as well. And people want to know, why are the nerves not calming down to their normal resting level when someone has persistent pain? And what we know is that the sensitivity of the nerves is determined by various factors going on in your life. So it's more than just a input and output system. Because of the complex neuro-matrix, all those other factors in your life are going to determine whether or not your system is ramped up. I often tell patients about neck pain I was experiencing last year, and I was working a ton on the computer in the evenings. I was working a lot at my private practice business too, but then also I was very stressed because I was trying to do too much essentially, and then I was not getting enough sleep, and I was sacrificing my nutrition too. So it was this buildup where I'd kind of hit my tipping point more or less, and so any additional stimulus, whether that be physical and other mental stimulus, too many emails coming in, all of those things were sensitizing my system and making me more susceptible to pain. So something that a single stimulus that used to not make me experience pain was now putting me over that tipping point and then setting the alarm off. So that's exactly what pain is. It is an alarm system that's letting you know what's going on. This is a great, well-built system in the acute stage. Step on a nail, we know to pull away because all of these things are saying, hey, there's a potential threat there, or maybe an actual threat, and we need to get away from it. But what happens is, in the state of persistent or chronic pain, when you're sensitive, when your system becomes more sensitive, that alarm system is now firing, let's say, inappropriately, or it can fire inappropriately. So we have this well-built alarm system, but then let's say you've had this pain for a while. If we're using the alarm analogy, let's say you have shoulder pain, but then if we're talking about your home alarm, you go on vacation, and then you leave, and your alarm is still going off. So like you're still having that shoulder pain, but then all of a sudden you start noticing that you are having some elbow pain or maybe some neck pain on that same side, and you're wondering, or your patients are wondering, why am I experiencing these other pains? And that's because using the home alarm system, if that alarm is going off, but you go on vacation, your neighbors are starting to wonder why you're not addressing the cause of that original alarm. So they're all starting to get frustrated because you left, but the alarm is still going on. So, or in the instance of pain, you're not addressing the situation. So the other areas are starting to become concerned, sensitized towards that pain, which is then perseverating the problem, making it worse. And then finally, once the system becomes so sensitized, things that previously maybe didn't even bother it are now contributing to pain. So if it's shoulder pain, and then you notice that you're not even moving your shoulder, you're maybe just moving your fingers, typing on the computer, even the action of working something well distant away from the shoulder is now causing problems. And so when the system becomes too sensitive over time because you're not addressing the original cause of the alarm or the overwhelming amount of factors that can be contributing to the alarm, then seemingly disconnected things are correlating with the original, are correlating to the problem. When the alarm system goes wrong. So nociception is the most common precursor to pain. And so nociceptive pain, if I smash my finger on something, or if I bruise my toe, all of that those are nociceptive inputs, and that's the most common types of pain people experience. Recent studies have found that thoughts alone can also activate the chemical sensors in the brain, causing these same warning bells to go off. So if we go back a slide, we're talking about how in the middle picture there, when the neighboring areas start going off, well, then we go to the right picture, all of a sudden, we're just thinking about doing an activity, and now it's setting off the alarm. So the mind is so powerful that even just thinking about a certain stimulus can then contribute to pain. And that's why patient education when it comes to chronic pain is so important, because we know if people have a better understanding of why they're experiencing pain and how the pain alarm system works, then we can help control the mind and we can work through that. So, final take-home points. When it comes to treating pain, especially persistent pain, using a multimodal approach that focuses on patient education, manual therapy, and exercise are going to be the keys to helping someone get out of pain. Finally, I want to review the regions of the pain of the brain that are activated when you're in a pain state. From the bottom up afferent stimulus is going on, as it gets to the brain, the thalamus is activated, which lets you know what type of input is coming in. So is it a thermal input? Is it vibratory? So what's happening there? The thalamus activates. That connects with the amygdala, and then that triggers past emotion and past experiences. So if you step on a nail, you're quickly processing, okay, last time I stepped on something, the amygdala saying that was a nail, or was it a small twig? Was that okay? We're also connecting with the somatosensory cortex, which determines the location and intensity of pain to help you pull away from that and guard from the potential danger. Prefrontal cortex activates, and that is going to be the big frontal lobe processing. So this can help minimize, inhibit, and understand the pain response. So our brains actually have the capacity to regulate how intense that pain output's going to be. So the frontal lobe is what helps inhibit or excite how much that pain response is going to happen. Lastly, the anterior cingulate gyrus and the insular cortex, they help register the pain as being as an unpleasant sensation. And all of these are happening in milliseconds. Ding, 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 ding. All parts of the brain are going off in that pain matrix to quickly let you know whether or not you need to address this. This can work really well, or if someone's system is being overwhelmed in a state of persistent pain, then that can be mangled and cortically smudged, would be a term that describes it when it's not working properly. So managing people with chronic pain is so complex because the standard walk to jogging program really does not apply in this situation. There's no common sense logical strategy, and that's why it has to be an individualized, tailored approach using exercise, education, manual therapy, and then also understanding what is that direct patient's beliefs and expectations. So if you have any questions on pain, please reach out to us. This one reviews why pain is like an alarm system and how to help people who have persistent pain through using this analogy. So thanks for following the Student Physical Therapist, and we will see you soon.